So PD1 blockade is a very important treatment modality in classical Hodgkin lymphoma. I mean, it's revolutionized much of cancer medicine, lung cancer, bowel cancer. A lot of things now use PD1 blockade, but actually PD1 inhibitors work better in classical Hodgkin lymphoma than in any other type of cancer. It's just other things work well as well, like chemotherapy, so that perhaps proportionally they've had less of an impact. We've been able to use PD1 blockade now in relapsed refractory classical Hodgkin lymphoma for some time, but really what we want to do is try and integrate them into the frontline setting to increase our cure rates, but then crucially to reduce toxicity rates. I think one slight issue with the way PD1 inhibitors have been developed in the frontline space is so far they're just adding on to current chemotherapy regimes. So, for example, there's a trial led by the SWOG group in the US, which is a very interesting trial. It's 6 lots of AVD brentuximab versus 6 lots of AVD nivolumab. And there's also a trial using pembrolizumab where you give pembrolizumab 3 cycles before chemo. You then have a sort of ABVD-based rattle approach, and then you have a little bit of maintenance pembrolizumab after chemo. The issue with that is patients are still having 6 cycles of chemo, and that means 300 milligrams per meter squared of doxorubicin, which has cardiac issues, and it also potentially lengthens the duration of treatment. Certainly that's the case for the C11 study, the pembrolizumab study. And these are young patients who want to get back to work or their studies or whatever it is really quickly. So ideally, we would actually go the next step, which is to integrate PD1 inhibitors in a way to reduce the chemotherapy burden for those patients who are responding well. So perhaps, for example, you might imagine a trial where you give 3 cycles of a PD1 inhibitor, do a PET scan. If you're in a complete metabolic remission, maybe only 2, 3, 4 cycles of AVD and then stop. Or, if you then have 2 cycles of AVD and that you're in PET negative remission, then maybe only 1 more cycle. So ways to response adapt and use the potential chemosensitivity that checkpoint inhibitors bring, for which there's, I would argue, emerging data to reduce the need for chemo in this patient group. So yes, improving cure, we hope, but also hoping to reduce chemo-related toxicity.